Welcome everyone to Blooducation Baristas, serving you piping hot transfusion news and now conversations on advancing medicine topics. I'm your host, Daniela Hermelin. I'm the Chief Medical Officer of Impact Life and Assistant Professor of Pathology at St. Louis University School of Medicine. Today, I am filled with emotion. I'm filled with gratitude to be having someone in my personal professional life that means so much to me to speak to us today. That is Dr. Neil Blumberg, who I always joke around is my Blooducation Tati. Why do I say that? Well, to me, it's really important to actually look at our professional legacy. Mentorship is so important in life, especially within our field and within the fields of transfusion medicine, within the world of pathology even. And I think that paying honor to those who have taught us and the legacy of teaching that information. So Dr. Blumberg trained Dr. Spitelnik, who trained Dr. Doug Blackall, who trained me. So I feel that I am a recipient of that inherited transfusion medicine knowledge that came from Dr. Blumberg. I'm proud to say that I am a child of his. Get him in trouble. Well, I'm proud to bring him on our broadcast right now. Dr. Blumberg, thank you for joining us.
Happy to be here. It's a privilege.
Well, I would love for you to share with the world. You are a 40+ year veteran of transfusion medicine, and when I think about the types of topics and concepts you have brought into our community, it's been expansive. Can you just share with us a little bit about what brought you to our field and a little bit about your own personal history in our field?
Sure. And like many stories, it starts with failure. I started out in a 6-year PhD program at Cornell, founded by the Ford Foundation, that sort of crashed and burned, and I got that literally burned, and I got out of there as fast as I could and moved to Yale, where I spent the next 13 years as a undergraduate and a medical student and a graduate student and then a resident and fellow. And those were really formative years, and I thought I was going to be a basic scientist with a little bit of clinical medicine, but I also crashed and burned in an MD PhD program and realized I was not going to make a good basic scientist. So the lesson there is failure. How you deal with failure obviously determines a lot about what your life is. And I wasn't sure what I wanted to do. And I started back then going internal medicine was the thing to do, but it was not very attractive for various reasons to me. So I started in laboratory medicine, which is also known as clinical pathology. I have no training in classic pathology, anatomic pathology. And the people who became my role models over the next 5 years were all internist hematologists. So I kind of, even though my boards are in clinical pathology or laboratory medicine, my mindset, my whole approach to many things is really that of my internist hematologist teachers. And of course, one of my most important teachers, maybe the most important, is my wife, Joanna Heel, who is a British trained internist hematologist. And so she continued my clinical training during the next 45 years after we met. And we've worked together in research. And whenever I had a clinical problem that was complex or puzzling, she was the one I went to first with. And often she had enormous insight from her own clinical training and her own wisdom and intelligence. So it's been a very, very privileged, and I've been very, very privileged in the people I've learned from, both early in my career and over the ensuing years. And of course, the group of colleagues I've had here in Rochester for the last 44 years in pediatric hematology, adult hematology, trauma surgery, pediatric intensive care, et cetera, have all been very important, both from research and a clinical standpoint.
It's a pretty incredible, your background. You're saying you sort of you fell in love, and on many levels, both to your wife and to the field within hematology.
Oh,
So you,
it's been an extraordinary journey. Very blessed.
yeah. And so I'm just curious, when you talked about your failures, what what do you, can you clarify what that looked like? What did it mean
Well,
to, in your mind, to fail in bench work or in the research area?
I think when you start out in a program that is ambitious, like the 6-year PhD program at Cornell or the MD PhD program at Yale, the assumption is you're going to finish that program and you're going to excel in it.
Mhm.
And I did neither of those things.
The thing is, it sounds like though that your background and at least those formidable years has definitely influenced your research perspective and your hardcore science perspective and how you conduct and how you see and how you approach medicine and transfusion medicine today. So I wouldn't call it a complete failure.
No. Fortunately, most failures, short of death or disability, are not complete failures. You can redeem yourself, and
Mhm.
redemption is one of the real themes of many aspects of life. I think the lesson, one of the lessons, is to learn your own strengths and to know what they are, and to be realistic about your weaknesses, and recognize that you're going to need other people, whether it be in professional or personal life, to compliment you. Compliment with a E, not an I. Although it's nice to be complimented with an I. For example, in my wife and I, in our collaboration in our marriage, for example, many of my strengths are, not the areas that she's strongest in, and vice versa, both in terms of personality and professionally. I had an extensive training in mathematics, statistics, basic science, and where she's much more of a clinician. She had much more extensive clinical experience. So that meshed very well, in that my laboratory background was very strong and her clinical bedside practice was very strong and very broad. She was trained in many areas of clinical medicine. The same thing happens in collaborations, and working with one of my major basic science collaborators, Rick Phipps. He's an immunologist, and he understood a lot about immunology that I was kind of vague on. Whereas, I had the clinical background to put some of the things in context that perhaps were not his strengths. And so the same thing with my clinical collaborators, both in research and, I think if you're dealing with a clinical problem, whether it be in transfusion medicine, endocrinology, whatever, knowing what you know and knowing who to go to get a different viewpoint or additional viewpoint is the key to being a good physician. And same thing holds probably in the law, medical technology, poetry, and 15 other things.
Implies, yeah. I I love how you said that. I love how you said you're finding a way to complement your own personal skills. And it's funny, when I thought complement, I thought about, IgG C3 complement, which is disgusting of me as a blood banker. But really what I also admire though about, how, at least for me as a mentor, and forgive me for saying this, but I love how you serve almost as an iconoclast in our industry and our profession, which when I say iconoclast doesn't necessarily mean to just reject something without having any thought to it. It's the exact opposite. It's teaching someone to be a critical thinker, to say, I see that this has been published, but let's really talk about this. Let's think through this. This is why this may not make sense. And I was wondering if you could speak about that. When I think of other iconoclasts, and I think about Dr. Goldfinger, who I miss very much, and a little, and Lou Katz, somewhat, is someone who maybe has a strong opinion, we could say, but someone who really thinks and causes you to be a critical thinker.
Well, I suppose it's always easy to look back and make up stories about how things happen. But I think early in my career, I was taught that, and one learns, when one looks at the history of science and medicine, the degree to which dogmas turn out to be wrong, the old joke, which is not a joke in many ways. In your first year of medical school, and maybe this happens in other other professions as well, they would say to us, at least once, we're going to teach you everything we know, and 50% of that is going to turn out to be wrong. Unfortunately, we can't tell you which 50%. And that's really the history of science and medicine. I can go into specific examples. I mean, the famous one in medicine, is Ignaz Semmelweis, who said, this is before the germ theory, he said, if you wash your hands before delivering babies, women won't die. And people laughed him off the stage. And even some of the great thinkers of our time, historians, including mentors of mine, who said, well, Semmelweis was a difficult guy and he was a troublemaker and all that, but he was right. And then you look more recently and you look at Bernard Fischer, who was a very, very famous surgeon, who said, I'm not sure we need to do this Halsted radical mastectomy. I think breast cancer is probably a systemic disease. We're doing a lot of harm by doing a radical mastectomy. Let's do a randomized trial. And it turns out lumpectomy plus another little bit of other therapy is much as effective and much safer for patients. Well, all these surgeons who'd spent decades doing Halsted radical mastectomies for the last century were pretty annoyed. And in fact, the reaction wasn't applause. It was hostility and anger. And so this is the way things change in life, is that when you challenge existing ideas, you're doing the right thing, because if you're collecting data and you're doing it the right way, and the problem is that it's very easy to do things the wrong way to try to defend dogma. I can give you examples of that. But I think the only way we're going to make progress is to look at the things that aren't going well, or where we see anomalies. I mean, we have cases that we discuss at our hematology conference, and we've got an 84-year-old hematologist and a 90-year-old hematologist. Mm-hmm. Got me, who's 76.
You're young.
Right, I'm the young guy of that group, of this group. And we have patients presented to us by our fellows, and occasionally we just don't know what the heck's going on. And so in that case, in clinical medicine, you ask other people for their opinion who may have different experiences than yourself. You think about it a little more, and you watch and you wait unless something's really emergent. And sometimes the answer becomes apparent, and sometimes you just don't know, and you never will know, even if you have an autopsy. So I think humility and open-mindedness, and those are difficult because it's kind of hard to get through the day. If you're open-minded and humble, you'll never know what to order for lunch. If you're constantly procrastinating, you have to make some decisions in life.
I remember just a few months ago, I was involved in writing a letter to the editor, and it was on a controversial topic. And I remember your advice to me, guidance, whatever you want to call it, which is, Daniela, in the end, we don't always know how things will turn out. So because I needed your blessing on this. I needed to get your blessing to write this manuscript, because I knew that it would have some type of controversial backlash. So I definitely, I love the fact that you see that, you have to stay humble in the medical process, and realize that, you do your best with what you have at hand at the time. And, you try to make the best clinical decision making. I do value, and I think we need better training, though, in how to conduct better and think about better studies. But maybe we could switch gears and actually talk about a topic that has some controversy. I thought we would start out with ABO mismatch transfusions, particularly platelet transfusions and plasma transfusions. I thought we might want to just start off by doing a little bit of a background of what ABO compatibility even means, and then talk about this concept of a major mismatch and a minor mismatch. Maybe we could just start there.
Sure. So one of the things that is very interesting in medicine and science is sometimes we come up with a model that works really well. And the model of ABO compatibility worked really well transfusion was illegal in Europe for most of history because when you just gave blood, people died. And with the discovery of the ABL blood groups, we discovered that people had antibodies to the antigens they don't have themselves. So that's major incompatibility. So we give an A red cell or an A platelet to an O individual. They've all got anti-A. So they've got antibodies that react with the cells, can often fix complement, can cause removal of the cells, dysfunction of the cells. And so that major incompatibility was what was causing most of the deaths. And then we had the successful model of so-called compatible blood. And that's because if we were going to fractionate blood, not give whole blood, we could give red cells, and there wasn't a lot of plasma left in there. So it was minor incompatible. There was a little bit of anti-A and anti-B in those O red cells, but patients weren't dropping dead. They weren't developing DIC, renal failure, et cetera. And so that model worked very well. And so we basically came to the conclusion that the only cells that really mattered were red cells. If you didn't hemolyze red cells, it didn't matter. Everything else was fine. That's totally wrong. But it's not as obviously totally wrong, because all the rest of the cells in the body have ABO antigens as well. So if you give a lot of anti-A to somebody who's group A, it may or may not cause hemolysis, but it's also going to bind to the endothelial cells, the hepatocytes, the monocytes, macrophages. We don't even know what happens. We can model it in vitro. And so major incompatibility is when the recipient has antibody to the donor. Minor incompatibility is when the donor has antibody to the recipient's antigens. And we've only worried about red cells in general. And in fact, we've come to the conclusion that ABO doesn't matter for platelet transfusion. And that's total nonsense. Why do I say it's total nonsense? It's because we have randomized trials, which are often not referred to because they're 30 to 40 years old. 2 randomized trials showing that 2 different models of giving randomly selected or major incompatible platelets leads to platelet refractoriness rates that are 2 to 10 times higher. And it's really interesting that the dogma has persisted. And in fact, there's a major hematology textbook, the chapter on platelet transfusion, it cites a bad study that isn't randomized and doesn't refer to the 2 randomized trials. Well, why do I say it's a bad study? It's not because people have bad intentions or they're stupid or anything. It's because they used in methodology that was unsound. And so if you look at patients and you say, we're going to classify them as the 2 studies, one in surgery, one in hem-onc patients did, based on their first transfusion, is it ABO identical or is it mismatched? And you ignore every subsequent transfusion when many of these patients got 4, 5, 10, 20 transfusions. That's not science. That's terrible science. You get 1 identical transfusion and 5 subsequent non-identical transfusions. You put them in the identical group. Well, it's scientifically irresponsible. I don't think people did this to be irresponsible. I think the problem, one of the biggest problems in science, and we all have experienced it, I think, is we try to make the data fit the hypothesis. We come up with a hypothesis and we get so attached to our hypothesis that we do silly things. And deciding that only the first transfusion counts in a patient who's getting many transfusions is bad data analysis. We're not looking at the data. We're not saying, well, what happens when a patient gets 3 ABO mismatched versus 5 versus 10? We always in medicine look for a dose response effect. We don't say, if we were testing penicillin versus chicken soup, and we randomly gave people penicillin and chicken soup and only classified them according to what the first therapy was, chicken soup would look just as good as penicillin.
Right.
So we've got randomized trials. And when we've looked at our data, it turns out that combining leukoreduction and ABO identical, avoiding infusing ABO mismatched antigen and antibody, our refractoriness rate is pretty much zero. Pretty much zero. And we didn't publish it in an obscure journal. We published it in the New England Journal of Medicine. And it's had exactly 0 impact. And that's because people are attached to the dogma. They're attached to the way we've always done things. So I've gone on a bit of a rant, and
No, not at all. What happens is my heart is beating fast because I'm one of those people that has practiced, transfusing incompatible platelets. You're saying that the outcome is that there's increased platelet refractoriness. So would you say that this is a problem then with those who require, many transfusions, many platelet transfusions, or, so that maybe practice needs to be changed within a certain population, or you really think that it should be a widespread practice, meaning all patients
this is a
could
very
receive.
important question you ask.
Yeah.
And unfortunately, it's much worse than we thought.
Okay.
When we looked at cardiac surgery patients, the patients who got ABO mismatched platelets had 50% more bleeding. They had increased length of stay. They had a 4-fold increase in mortality.
Mm-hmm.
When a group at Columbia recently looked at patients on antiplatelet drugs who had head bleeds, who frequently in the past have gotten platelet transfusions, they found that the patients who got major incompatible transfusions had statistically significantly more bleeding after the transfusion and higher mortality. So, and when we modeled this in vitro in the laboratory, this is work done by my colleague Majid Rafai, among others, we showed that exposing platelets or endothelial cells to incompatible antibody or immune complexes in the ABO system destroyed the endothelial monolayer. And in fact, the group at Columbia, led by David Rowe, who's a neurologist, and Eldad Hod, who's a transfusion medicine physician, they now have MRI data showing that in these patients with head bleeds who got ABO major incompatible transfusions, they had vascular lesions throughout the brain. So we're not seeing this. It's not like these patients are keeling over or suddenly developing a stroke, and had a stroke, but it's clearly increasing morbidity and mortality. And this is probably true in all patients. Is one transfusion of a group O platelet to an A recipient likely to cause all these problems? Probably not, because you've got a little bit of antibody and a ton of antigen. So the amount of antigen per cell or per protein, you have to remember von Willebrand factor carries ABO antigens. Do you really want your von Willebrand factor to be coated with IgG and IgM? Maybe not. It's a theoretical hand-waving argument. So the answer to your question is you've got to start small. We introduced this in 1990 for patients with acute leukemia because we had shown that they became refractory, and refractory is bad for patients for all sorts of reasons. But then when we saw this in cardiac surgery a few years later, we started in 2005, which is 15 years later. Our technical staff have done a magnificent job under the leadership, particularly of Deborah Maisel, our chief supervisor. They found ways of giving ABO identical to everybody, or I know this is going to, people are going to be making the sign of the cross and hanging garlic. But we actually washed some O platelets in red cells, which I know is a heresy. But it turns out our bleeding rate, just to give you an idea, Daniela, there's a hematologist, a Dr. Ipma, who for her PhD thesis in the Netherlands showed studies with the rates of bleeding. And our study was down at the lower end. We have about a 1 to 3% WHO grade 2 bleeding rate. Charles Schlichter in the Plato study at the other end of the spectrum had a 70% rate, so almost a 50-fold difference in bleeding. So the thing to do is to introduce it, as you suggest. I think there's the follow-up to your suggestion is if you start small, let's say with patients with acute myeloid leukemia, or maybe allogeneic, ABO mismatched allogeneic transplants, where you have a defined, relatively small group, and try to give ABO identical to them. So they learn how to do it. And then eventually, maybe extend it to other patients, autologous transplants, myelodysplastic syndrome, acute lymphoid leukemia, and maybe eventually cardiac surgery or liver transplant or something. But it's not something you can do overnight. As you know, if we had platelets that we could store for, 42 days, like for red cells, it probably wouldn't be that difficult to give abiodentical. But
Yeah.
day out date, it's logistically difficult. But I think the first step is to recognize we're doing harm with our standard practices. Let's try to slowly start to change that.
Mm-hmm. And so just to summarize, the pathophysiology that can lead to issues of transfusing incompatible plasma is really that you have antibody that once all of it is attached to the soluble antigen, it can also then attach to antigen that's presented on the endothelium or other organ systems.
Right.
And from there, it could lead to complex formation or endothelial injury. And that can lead to bleeding, you're saying?
Yeah. And giving a little bit of antibody is probably less dangerous than giving a little bit of antigen. We know that if we give A red cells to O recipients, many of them will have catastrophic effects. If we give O whole blood to A recipients, occasionally we'll get, massive hemolysis, but it's not very common. So this is partially a Le Chatelier's principle. The quantity counts.
Yeah.
Counts, whether you're giving a lot of antibody, a lot of antigen, or a little bit of antibody, or a little bit of antigen. And I was a little bit surprised by Eldad Hod and David Rowe and their teams finding that even just giving a single platelet, that was ABO major incompatible, led to catastrophic events in their patients on antiplatelet drugs. And it may be that those patients are particularly vulnerable for some reason.
Maybe
they already have vascular damage of some sort.
Yeah, I think that for me, I remember as a trainee and even earlier on in my career, I was actually concerned about the acute hemolysis that could happen with incompatible plasma. And to my surprise, I only saw it one time where an O platelet was transfused. So otherwise, I have never seen acute hemolysis when we transfuse group A plasma. And we do that randomly now because we have access to it, and we transfuse a lot of that in the trauma setting. And I have not seen I personally have not seen, and I don't think I've seen a case report of hemolysis in those situations. So in my mind, there's two different types of pathophysiology. We're talking about the acute hemolysis, but then really what you've shown is that it has more of that endothelial injury from immune complex formation, which can lead to immune modulation, which leads to platelet refractoriness or increased bleeding.
Right. I think, acute hemolytic reactions are the extreme.
Okay.
What we haven't studied extensively is what about low-grade hemolysis?
Okay.
Patients who aren't developing immediately renal failure or DIC, hypotension, blah, blah, blah.
Yeah.
And we have models of nature that suggest that low levels of hemolysis are very, very bad for patients, particularly if they're on a chronic basis. What am I talking about? As a hematologist, I'm talking about sickle cell anemia. I'm talking about paroxysmal nocturnal hemoglobinuria. And these diseases are episodic and chronic hemolysis. And as we know, these patients can have terrifically complex and fatal courses, including these terrible vascular occlusive events, acute chest syndrome, and in PNH thrombosis. So low levels of hemolysis that don't involve peeing red, which is all we blood bankers seem to worry about.
Yeah.
Low levels of hemolysis, not good for your kidneys, not good for your endothelial cells, not good for inflammation. Free hemoglobin, not a good thing, even in low amounts, probably.
And is that how you would monitor it, this so-called low level of hemolysis, just monitoring free hemoglobin, or are there other ways?
Well, that's a good question, and I don't think I know the answer for sure. I can tell you that in our research studies, free hemoglobin is cleared very quickly. And so what you can monitor is haptoglobin. And if the haptoglobin goes to 0, and it doesn't take much free hemoglobin to do that, the amount of free hemoglobin in one transfusion unit of red cells, especially an older unit, can completely clear your haptoglobin. And in fact, newborns have almost no haptoglobin, as it turns out. So that's one thing to do. Many places in our hospital has never had a free hemoglobin assay. So I don't know quite how to monitor this clinically, but I think, once again, believe what's in front of you. They call them vital signs for a reason. And if the patient is able to communicate, asking them how they're feeling is very important. Monitoring their creatinine or some more sensitive test. We don't study it here much in the clinical setting because we don't have much hemolysis, because we're not transfusing except in the trauma setting, ABO mismatched transfusions.
Right.
Pretty much 0 now, but it took us 30 years to get here.
Yes. Well, I'd love to talk to you about another topic. We could call it controversial or not, but that's whole blood.
Sure.
And whole blood is a super hot topic. My favorite meme is I created one that has Indiana Jones over one of the special like golden artifacts, and I said this is the trauma surgeon holding a unit of whole blood. We love whole blood, and perhaps it will be the holy grail. I think we're still trying to understand it, but in this case, it is an example of possibly transfusing incompatible product.
Right.
Not when it comes to the red cell portion, but possibly the plasma portion. Right. So what are your thoughts about that?
Well, I think the published experience with whole blood has been very educational to me personally, in that we would have predicted, based on the dogma, that this would be terrible. Just like giving A plasma instead of AB plasma would have been considered terrible. And so what it tells me is that small amounts of anti-A and anti-B, probably not so bad. Now, the problem, as we mentioned, I think in the review you are going to have on the website, in this very short paper we wrote for Frontiers in Bioengineering, is that what we're comparing whole blood to is component therapy. What is component therapy in the trauma setting? Well, it's so-called universal donor O red cells, and then any old ABO platelets, A plasma, and any old ABO cryoprecipitate if you're using cryoprecipitate as fibrinogen conjugate. That is ABO mismatched to 100% of patients. So we're comparing O whole blood, which is identical with 45% of recipients. Component therapy, which is ABO mismatched with 100%. So and that we make this is a hand-waving argument. I'll be the first to admit that. I don't have any, other than the fact that we've worked on ABO and platelets for, 40 years. I don't have any special data or knowledge on this. But if you tell me 45% of the patients getting ABO identical versus 100% getting some ABO mismatched antibody and antigen, would not surprise me if the ones that are ABO identical, with some of the patients, almost half the patients, might do better just because of that. Now, I know the trauma surgeons and some of the people who are pushing whole blood, Mark Yeaser, Phil Spinella, are saying, oh, it's a better product. It's got more platelets. It's logistically easier, which no argument there. I mean, one bag instead of 3 or 4. But when you say it's got a little bit more platelets, do I think that's making any difference? You could knock me over with a spoon if that's, the amount of platelet. I mean, most of these patients are not coagulopathic. If I look at thromboelastograms, viscoelastic tests, literally thousands of patients in the last 10 years. Almost none of them are hypocoagulable by viscoelastic testing. Many of them are hypercoagulable. So the thought that we're going to actually fix something by giving plasma or platelets to somebody who needs 4, 5, or 6 red cells seems most unlikely to me.
Yeah.
I think the real advantage of Group O whole blood is it's ABO identical and it's low titer.
Right. And then logistically, like you said, it has that advantage. I'm very involved in helping to implement pre-hospital transfusion practice. As you probably know, getting blood on helicopters and ambulances. And, what we're seeing is that over 50%, let's say 50%, is helping in those patients that have medical bleeding, not just traumatic bleeding. So to your point, I do think component therapy would probably just benefit those patients, meaning just giving them a red cell. They don't need platelet. They're not depleting their blood volume to only where 30% of the coagulation factors are remaining. And I even remember when I was helping to run the hospital trauma, transfusion service, we have something called a trauma pack. Those are 4 units. They like whole blood, but once they're finished, it's red cell. But let's just call it the trauma pack. And that gets delivered to the trauma bay immediately. They also have it now in refrigerators, a trauma pack, 4 units. And I studied how many of those 4 are transfused, and I looked at a year of data. And to your point, really most traumas come in and they only need 1 of the 4. Most require 1 of the 4, which tells me that they're not bleeding out. They have something that requires transfusion, but not enough to probably replace total blood volume in a way that's necessary, where they're going to not have the ability to form a clot.
Right. Yeah, I think I'm persuaded. The randomized trials haven't been finished, and I wouldn't be surprised if whole blood is not amazingly superior to other things. But I think the observational data suggests whole blood's almost certainly not worse than component therapy. We know that. So if the surgeons prefer it, and we can make some pretty good hand-waving arguments, as I just did, that it should be better based on what we know. For maybe not for the reasons that some people believe, but there are a lot of possibilities for why it might be better. And so we've been using whole blood for a few years here. Our helicopter people are using whole blood. We have mostly blunt trauma, which is a very different animal. I'm not a trauma surgeon or an intensivist, so let me just state that. But it's clear that patients who have blunt trauma are different from people, who've had high velocity projectile injuries from guns or from knives or other things, or the sort of things that happen in the military setting. So I think our blunt trauma patients are a different category. And the patients who start to massively hemorrhage in hospital, such as GI bleeds or intraoperative bleeds, can be managed with components most of the time. And they're usually ABO identical components in our case, because we know they're ABO type, because they've been inpatients, whereas we don't with the trauma types. Although we have emphasized, and our trauma surgeons have been very enthusiastic about cooperating, to one of the first sample that they get is not a metabolic panel or a CBC or catecholamine levels or whatever. Get a sample to the blood bank so that we can get you ABO identical components, at least for the A's and the O's. It's not so easy for the AB patients, obviously, especially in the perhaps non-level 1 trauma setting, and you don't always have an AB platelet or a B platelet. The good news is that AB patients and B patients are not as susceptible to hemolysis or injury as A patients, we think now. Think about it. Anti-A is biologically by far the most potent antibody of the two, A versus anti-B. And the density of A antigen is much greater on A red cells or A endothelial cells than on AB cells. 50% lower. So, whole blood, it's interesting when we look at our trauma patients, our B patients do pretty well. We have unpublished data that our AB patients do very poorly. And it correlates, not in the first 24 hours, but getting out of the hospital alive, it correlates with the volume of ABO mismatched transfusions they get. It's not a randomized trial, but it just shows that this fits with what we know about the potency and biology of anti-A and anti-B. So I think if you don't know the patient's ABO type, you give them O red cells. And in our case, we give them washed O red cells if we have the time. And if you don't have the time, you give them group O red cells or group O whole blood, preferably a low titer, because it's better to give 1 to 100 or 1 to 200 anti-A than it is to give 1 to 2,000 anti-A, because quantitatively it's going to be different. Anyway.
Do you think that there's a need or a place for a study? It would be something more, that we would do on the bench, but trying to replace total blood volume with whole blood and looking at, when we would notice a positive DAT or something like that. Do you think that there's something that would be worthwhile, especially with the anti-B?
Yeah, I think that there are. I think you're pointing out to the fact that you can, while it's not 100%, accurate, you can try to model what's going on and use surrogate tests for what we're concerned about, which is how much antibody is present on the average cell versus, and how much does it take to activate complement, and how much hemolysis do we see in vitro. And it's actually not that easy to induce hemolysis in vitro with anti-A or anti-B. Clearly, there's something very different that happens in the body where you don't have, where you have calcium and all the other things that you don't have in chelated specimens, or in serum or plasma. I mean, all the plasma we have, unless you're using heparinized plasma, if you use EDTA, you can't model the effects of calcium, and calcium is very important in obviously in complement fixation. So there are a lot of in vitro models that could be tried. One of the studies I've been longing to do, but we seem to have not gotten around to, is what happens to von Willebrand factor activity, both ristocetin cofactor and its factor VIII activity, when we expose von Willebrand factor or factor VIII to anti-A. In other words, take von Willebrand factor from somebody's group A, because if we're giving people acquired von Willebrand disease by giving them enough anti-A, we want to know about that, and you can model that in vitro.
So that's something you'd like to look into.
I'd like to have somebody look into it. It's always easier to get something done if you imagine somebody else doing it.
Yeah. Well, that was very enjoyable, actually, to go through that mental exercise with you, and learn your thoughts on these two, quote, controversial areas. I think that are hot topics. I'd love to go back to something that you started with. I want to learn more about how your wife has played such a role in your career. It's very unique, I have to say, and just to have that, like you said, that complement in your life.
Yeah. Well, we didn't set out to do that. We set out just to get married, and we were each kind of working on our own thing. For those of you not familiar with, I kept my maiden name when I got married. My wife kept her name because it's actually a pretty well-known name in England. Her name is Joanna Heel, and there's a very famous store on Tottenham Court Road called Heel's that her great grandparents founded in the 170 years ago or so, give or take. Anyway, and it's very well known for its furniture. Anyway, Dr. Heels, an internist, hematologist, oncologist, trained originally in England, came to the States. And we met actually because of the field of transfusion medicine. She came to train with a wonderful clinician and leader named Joseph Bovey, who was the director of the blood bank at Yale for many years, and may have been the first full-time director there. Anyway, she came to train with him. She'd been in the Red Cross Fellowship Program and wanted a more clinical environment. And so we were introduced by an ex-girlfriend who didn't want to be an ex-girlfriend. I probably shouldn't go into these sort of details. But anyway, and so we wound up together. And as time went on, she had some ideas that really seemed best explored as a collaboration between the blood center where she was, the irony is I was in the hospital. She's the better clinician, and I'm in the hospital, and she's in the blood center. And she was seeing a lot of patients through therapeutic apheresis and eventually transplant. But the story of the ABO system is she was the first one to raise the question of that whether ABO and platelets had been misunderstood, because we have this idea of compatibility, which was based on red cells, which had no plasma in them, and the platelets had 1/4 of a liter of plasma in them. And so she was the one who invented this concept that maybe minor incompatible platelets are different from major incompatible. And of course, there are platelets that are both minor and major incompatible. If you give an A platelet to a B recipient, they're both minor and major incompatible. And so she had a lot of great ideas, and I'm always happy to steal other people's ideas. We actually collaborated, and it was very important to me that knowing that women's work is often devalued, even in our present society, that we be equal partners. And I can honestly say there's not an important idea that I've ever had in my life. When I say important, I mean something that turned out to be useful and correct as opposed to woefully wrong, that I haven't run by her, and she'd critique it. And we would just, it became second nature to us as we're raising children, paying off mortgages, and doing all this stuff. It wasn't the most relaxing life. And it's interesting that neither of our children have become physicians or scientists. And probably there was too much dinner table conversation about hematology and research blood transfusion. But I've been truly blessed. I mean, there's no way we could have planned this. And it's clear that this was an example of synergy that I have no doubt in my mind. Of course, I tend to be more certain about things than she is. But that without her, I would not have, whatever I've achieved, I would have only achieved a tiny fraction of that, because it's really been a synergistic relationship. And, I think it worked for lots of reasons. I mean, obviously affection and time together and all that matters, but I think we were ideally suited as collaborators.
Wow. Something really, what a blessing.
Very fortunate, I mean.
Yeah. Well, then she's watched your whole professional journey, and you've had so many roles, including, editor of journals. As you look into the future, what do you see as some really interesting or promising changes that are happening? What's on the horizon for you?
Well, not for me personally, perhaps, but for the field. I think patient blood management has been an extraordinarily important change of philosophy, which is that we would like to treat patients with the least toxic, most effective therapy, and that in a lot of clinical settings, that's not transfusion. Patient blood management is no longer about avoiding transfusion unless the patient is, Jehovah's Witness or otherwise refuses transfusion therapy, and that's that's worth a whole nother hour at least. But I think people like Aryeh Shander, Shannon Farmer, Axel Hoffman, and more recently Steve Frank and Tim Hannon can go on. They're mostly anesthesiologists.
Yeah, it's interesting.
And they don't have a vested interest in blood transfusion the way we do. I mean,
right.
I can remember a colleague of mine, friend named Jay Menatov, who, when we were talking about artificial blood in the 1980s, said, "We're not going to have jobs." Well, right. that turned out not to be a problem. But, I understood what Jay was saying. But, for the rest of the medical profession, if we never had to transfuse anyone ever again, it's no skin off their nose. If the anesthesiologists can take care of their patients without transfusion, they're fine with that. We might be a little, we might have to sell insurance or something. But anyway, so I think patient blood management is not going to make transfusion irrelevant. I think it's still the only thing we have to offer patients with life-threatening anemia or bleeding. Until we come up with drugs that can treat leukemia without making that patient cytopenic, that's going to be a major use of particularly platelets. So I think I wouldn't discourage people from going to the field because of those concerns, but I think we need to work with your if your patient blood management program is outside the blood transfusion service, we need to work, as partners with them to improve patient care in whatever we can. And we have our laboratory resources usually that we can use to, we need to do ferritins on people and iron. But this is the most undertreated disease in the world. So that's one thing. The second thing is I think we need to come to terms with the fact that transfusions are much more toxic than we thought. So we need to do two things. One, not transfuse patients who don't need it. So we need to have less transfusions, fewer transfusions in some patients. And we need to do things to make transfusions less toxic. And here I'm definitely going to go into a minefield of controversy. You can see where I'm going with this. We need 100% leukoreduction, universal leukoreduction, because no patient should be exposed to the life-threatening risks of leukocyte-containing blood. We don't want to be infusing white cells, DNA, histones, neutrophil extracellular traps into the veins of a patient where they go directly to the lungs. They also predispose to inflammation, poor immune function against infection. They probably are a major cause of acute lung injury and even congestive heart failure, Trolley and Taco. So universal leukoreduction should be something that our professional associations like the AABB and the FDA should mandate in the interests of patient care. The costs are minimal. The benefits are maximal. We also need to find ways of making transfusion less toxic. One of the thoughts was, well, if we store blood less days, they'll be less toxic. The randomized trials did not bear that out. I can tell you from our randomized trials of wash transfusions, and our wash transfusions are undoubtedly suboptimal. We were using saline, which is not the right solution to be washing cells with. We showed decreased transfusion inflammation in cardiac surgery. This is a randomized trial, so we're kind of like not making this stuff up, that making the data fit our hypothesis. And we show, most importantly for me as a hematologist, we show that in patients with acute myeloid leukemia, we could extend life in these patients. The 5-year survival rate of acute myeloid leukemia with favorable prognosis is 80% in our hospital, as opposed to 50% at all the other teaching hospitals in the galaxy. Now, I know washing is not something people want to talk about. It takes time, it takes money. There are all sorts of, fanciful, dreadful dogmas. If it injures the red cells, it injures the platelets and all that. I said, well, it might in the laboratory, but in the patient, it saves lives. It reduces toxicity. There's a lot of work that needs to be done to know when this would be most useful, how we should wash cells, when we should wash cells, what sort of cells we should wash. We're pretty much the only people who've studied this in any serious way, but I think it has promise for reducing toxicity because the stored supernatant of platelets and red cells are toxic. When Chris Silliman and his group in Denver said that neutral lipids in stored red cells cause Trolley, you'd think he was insulting people's mothers. Well, of course, only antibodies can cause Trolley. And of course, that's total rubbish. But we've had the successful model studying antibodies in blood banks since 1905 or 1901 or 1910. And it is really, really powerful stuff. And so we became convinced that the only part of the immune system that matters is antibodies. Natural cells, T cells, monocytes, macrophages, endothelial cells, none of this mattered. And the only thing that could injure the lung would be anti-white cell antibodies. This is crazy. There's tons of stuff in stored blood. We have yet to see a case of Trolley or Taco in a wash transfusion, and we've transfused hundreds of thousands of wash transfusions. We have yet to see a febrile reaction. People read in the textbook, use wash transfusions to prevent allergic reactions or an anaphylaxis, and that's true. But it also prevents febrile reactions.
Yeah.
We took our rate in people having recurrent febrile reactions, rigors, fevers, to platelets from a 20% rate in a group of patients who were very susceptible. When we put them on washed red cells, we reduced their transfusion reaction rate by 2 orders of magnitude, from 20% to 0.2%.
Wow.
So there are mediators in the blood and stored stuff, membrane debris and
Yeah.
vesicles and stuff we don't even understand. So my goal would be to get people thinking, maybe we want to try moving this stuff after storage. And it'd be nice to have a bedside washing device the way the anesthesiologists have. So, you collect blood from a wound and you wash it before you reinfuse it. And so reducing the toxicity of transfusion, I think, is very, very important. Obviously, thanks to the work of people like Barry Blumberg, no relation, and Harvey Alter and many of their colleagues, we no longer fear infectious diseases, which were the main transmissible diseases due to transfusion. I'm sure there's still a few out there, and there'll be some new ones. But pathogen reduction, could solve that problem. It has for platelets. It will largely for plasma in the long run. And there will be new diseases. So pathogen reduction is great. And I will mention one more ABO story. And I hope that my colleague, Aquia Asante, who's working on this project with a PEDS Hem-Onc fellow, Laura Duarte, we're looking at IV gamma globulin and asking the question, what's happening in terms of low-level hemolysis in patients who are Group O versus Group A?
Okay.
And we have data that it not only major hemolysis is not the only problem. These patients are experiencing, probably due to anti-A in the IV gamma globulin, higher levels of hospitalization and early mortality. And so the manufacturers of IV gamma globulin, who are already starting to work on reduced anti-A and anti-B, because of concern about hemolysis, that hopefully this will hasten their work on this. So those are some of the more important things. And the thing I would say to people is pick something pretty important to work on. It's probably not the temperature of the water bath, though you want to make sure the temperature of the water bath is, fine, and you document it every now and then. But we're not going to save any lives doing that, probably. Find something that seems important, something that seems anomalous. Collect data, observe things, believe what's in front of you. Talk to patients if you're in a capacity where you talk to patients. Find out what's bothering them, because some of the things are not biologic per se, and we're not going to stop somebody from being anxious or feeling fearful of injury or death or what's going to happen to their children by washing transfusions. But you may be able to do something that can help those patients, depending on what your role is. And one of the great things about transfusion medicine to me is we are the only treating physicians in pathology and laboratory medicine. We use laboratory data to make vital clinical decisions. I think pathology and laboratory medicine could have been better custodians of transfusion medicine during my 50-year career. It really kind of is the red-haired child, so to speak. Nobody really understands what we do or sympathizes with what we do, and sometimes they say some incredibly negative things to our residents who want to go into transfusion medicine. But I think our colleagues in hematology and trauma surgery and intensive care medicine, emergency medicine depend on us. And one of the things I learned during the pandemic is without my technical staff out there in the lab, we have an 880-bed urgent care center. These are the people in pathology and laboratory medicine who distinguish this center in a way that almost nobody else in the department does. I mean, obviously, you need the chemistry lab, the hematology lab, you need to be able to do frozen sections. But this is the thing that keeps us operating as something other than an urgent care center. And so those technical staff are very important. And so if you're going to run a blood bank as a physician or a DO, or whatever your background is, take care of those people, advocate for them, make sure that they are secure and happy. And if they get mistreated, make sure that it's addressed.
Beautiful. Couldn't agree with you more. But it sounds like our field is promising, and we should be encouraging residents to pursue transfusion medicine and for MLS to pursue blood banking, and that it's a field that has so much promise and so many opportunities.
And it makes a difference to patients and to our colleagues in other areas of medicine. And one of the things I would like to see happen is to have more people with primary training in a clinically oriented bedside specialty like pediatrics, medicine, hemonc, anesthesiology. There are some people in the field, who've moved into transfusion medicine at least part-time. And I think they have a lot to offer us because we are treating physicians and we need more people with that sort of orientation. I'm not saying the pathologists aren't doing a good job. I'm saying it's a field, as you suggested, that is so enmeshed in the clinical milieu. I sometimes jokingly say, except for psychiatry and dermatology, everybody needs these people in the blood bank. And it is an opportunity to really remain enmeshed in the broad expanse of clinical medicine.
Absolutely. Well, we really covered a lot in just an hour, and it was so educational for me. Are there any last words you wanted to offer our listeners today about the profession, about your life, about your?
No, I thank you, and I'm very grateful for the opportunity to talk about these issues. I've been very blessed in many ways, both by the people around me, and this is just a shout out to all the medical technologists who work in blood banks and blood centers, because they have such a big impact on patient care, and they are often unrecognized, underpaid, and unappreciated. But this is a shout out to them that you make modern medicine possible in a way that almost nobody else in the field of pathology and laboratory medicine does. I mean, everything everybody does is important. I mean, I don't want my prostate biopsy being read by some idiot, so I'm not in any way, but I think these people are very, very important. And they haven't gotten the recognition either within laboratory medicine or even within transfusion medicine. I think it's really a team sport, and it's been a real privilege to work with so many great medical technologists through the course of my career.
I can't imagine a better way to finish this conversation. Thank you for honoring them, and I couldn't agree with you more. But I also want to thank you for all that you've done and your dedication, your lifetime dedication to our field, and always being courageous to swim upstream and teach us how to be critical thinkers, and thanking your wife also for championing with you along this. So
anything I have achieved, she deserves at least 50%, maybe 51% of the credit.
Beautiful. Well, I want to thank everyone for joining us today, and we will see you next time. Take care.
Bye-bye.
Bye.